Okay, good, man. How you doing out there in Idaho?
Doing pretty good.
Okay, good stuff. Good stuff.
Happy birthday.
You were in Dr. Graham's presentation, right?
I was. Yep.
Awesome. Yeah, he covered it really, really well.
Yeah, it was
Uh,
really
did a really good job. So I'm excited to see what you have going on as well. So I would like to introduce Dr. Karson Howard, who's going to give a little case study presentation, which I'm sure you'll all find really valuable. So take it away, bud.
All right, you're gonna have to remind me how I share the screen. Oh, I remember. Okay.
Well, you don't need to close out your camera.
Oh, not that one. All right.
The one next to it. That's because you guys were talking all about skiing and everything else that was happening on the when we were training there.
Having too much fun. Yeah. All right. As soon as I get this right, I'll be set.
Okay.
Because I remember the application window has to show it.
Yeah.
And I had it showing.
You got to have it loaded.
Okay, let me load it here.
Yeah.
All right, let's see if that.
People still coming in the room too, so I mean that's fine.
Okay.
Yeah.
Thought. So I can see I can see it here. I have it open.
Okay, now go back to me and hit the share screen. Your screen's bouncing a little too.
Okay, I'll fix that. It's just on my lap at the moment. So.
Yeah. Wow, that's a close up. Hey, Karen. Okay, so what do you got?
Well, I had this working yesterday, but so I'm on my Mac here. I am. I see it here, but it's on. I have it full screen.
Okay. Well, you got to be on drag. Just drag it over to the side so you can get to where I am.
Okay, let me just maybe do a half screen or something.
See, we all have technical. We're all technically challenged in one way or another.
Yes, we are. All right. Well, I have my screen split here.
Okay, so now with me, you should be able to go share screen, application window, or share full screen.
Yeah, maybe I'll just share the full screen.
There you go. Now just find your presentation. Oh, there it is. So now just click over there and start that up. There you go. Perfect. That works. Okay. Right. See, you could. Okay. Hit the next just so I can make sure it's going before I get off this. You're good. Awesome. All right. Good job. Take it away.
All right. All right. Well, I'm Dr. Karson Howard. I'm a podiatrist. Practice over here in Idaho. I've been using this SensorMedica platform for probably around three and a half years. So the nice thing about the one I'm presenting today is a patient that I saw 3 years ago, and then I just saw him recently this last month. And it's kind of interesting because I have the gait assessment using the platform 3 years ago, and I had it today. So it's kind of interesting to see how, as his foot progressed, we can see some of it on this platform data as well. So in 2018, I used to work over at a wound clinic, and that wound clinic has now closed. But when I was there, I saw this 63-year-old diabetic male, and he'd been over there for quite a while before I started up with this clinic. And they had been treating him for a sub-IPJ hallux ulcer. they weren't getting quite the progress they wanted when I came in. And so we tried a total contact cast and a different cam boot to try to offload this, while they did hyperbarics and other wound modalities. But as I looked at his foot, really there was a big issue associated with how much motion was in the first MPJ. And then it was also pretty clear that there was a tight gastrocnemius muscle. Further workup was done at this time just to see about an MRI and some x-rays. The MRI was suggested possibly that there was a distal phalanx osteomyelitis. However, this did not appear to be as close to the ulcer as I would have thought. So I wasn't as convinced, and the MRI didn't show any bone erosion. So I kind of wasn't going to, and the wound also didn't probe to bone, so I wasn't 100% convinced here. He did have some x-rays that were taken in January 2018. Here you can see the first MPJ, the second MPJ, and then right about up there by the head of the distal phalanx, you can appreciate the joint there. It's a little cut off in this x-ray picture. And then here's just the MRI report, just to show what I had said. They said perhaps there was some abnormal infiltration of the distal phalanx, but there was no bone destruction. So with this being said, I talked to him about the difficulty in treating this wound. And so we decided to go ahead on March 16th to go ahead and do a procedure for him. At that time, Cartiva was a little hot topic and being used quite a bit. It's a little joint implant that you can kind of see that little image there that you put right in the first metatarsal head. It's made of the same stuff that they make contacts out of. It's just a nice little plug. It's a quick little drill, and you just push it in, and then it gives increased range of motion. I also at this time did a endoscopic gastroc recession so that the Achilles wouldn't be pushing into his forefoot. And also I did the implant with hopes that it would just increase a little range of motion, just enough to get pressure off of the ulcer underneath the hallux. This is kind of what a Cartiva implant looks like. You get this big hole that you drill, and so x-rays always look a little funny. But this was the one I took at the day, a few weeks after his surgery. It does have a little piece here that I could have probably smoothed off a little better. But overall, you can kind of see where that implant went in. And then you can kind of see how it creates this space now in his joint so that the hallux can dorsiflex. After the surgery, I was able to take a gait analysis. And pretty much this is where on the right side, he had the hallux procedure. On the left, he has no procedure. So on the right, you can kind of appreciate how the hallux still comes down and hits the ground in his stance and weight bearing and during his gait. However, it's not nearly as intense as it was on this left side here. So as we watch him walk, we can appreciate where the center of pressure is, as Dr. Graham taught us, the white line here. We can also appreciate the red line, which is a lot smaller. Hopefully you can see it on the screen, but you see it jumping on the left side from the fifth met head over to the second. And on the right side, it went from the center right to the second. On the right side, it didn't go to the fifth met head, although it is lit up. It definitely doesn't have, now it finally shifted over to the fifth with that red line. But as you see, as he's coming through, if you're going to compare the right to the left, it no longer has the same amount of pressure as it used to have on the left side here. And I think that's why he was pretty successful in this healing his ulcer at the time. Here you can kind of appreciate the second metatarsal, third metatarsal head was about 23% load. I don't really go off of the numbers 100%, but now that I have a before and a couple years later after, it's kind of interesting to see how this number will go, and we'll get to that number down the road. But this data, it'll break down your hallux pressure, your metatarsal heads, and you can kind of just line it up according to the frame. This one I also took shows the same foot right after surgery. And when you look at the left side, for example, that's the left image and then the top center image of the graft here. You can see how much, so if you look at the blue curve here, you can see how little time of the heel is on the ground versus how much pressure is put on the forefoot there. And you can just constantly see it rise, rise, rise as he goes through his step. Now, when you look at the right one and you look at the blue heel line, which is the back, the blue arch, the dark blue one, you can see how much higher the heel is on the side that had the gastroc equinus procedure done versus the left side, the heel doesn't touch the ground. So it was pretty successful that the gastroc recession was able to bring his heel down a lot more to where I wasn't having as much pressure, irregularities between the rear foot and forefoot. So here's a quick picture of in 2018. If he just stood there, took a quick images of where his pressure's at in static. Now, he came back to me this year, and the hallux is starting to get a callus again. And not only that, but you can kind of see how there's a little toe sandwich between the hallux and the third digit. The second toe has drifted dorsally in a hammer toe condition, and it's you can kind of appreciate it here a little bit, but that second toe is rather dorsiflexed at the MPJ, consistent with a plantar plate tear. So I was curious how this happened. Obviously, in 2018, we got him healed up, and he was doing pretty good. But now, 3 years later, he's getting the callus back, and now he has what looks like a plantar plate tear and a potential other area of ulcerations. I took x-rays then this year, and you can kind of see how whatever little space I had between the first MPJ, the proximal phalanx, and the head of the metatarsal on the sagittal view, it doesn't have that spacing like it had before. And on the AP view on my left x-ray, you can see how there's just no more joint space there anymore. So that Cartiva implant had completely smushed, and I think it lost all its spacing. It's actually not a implant I use anymore, but it was very curious to see the 3-year follow-up, which tended to be quite different than what they said it would be in 3 years. What they said it would be in 10 years is definitely not the case. So not always accurate what they claim. So I took new gait analysis, and here we are again. Now here's his right foot. You kind of remember the right foot in 2018, what it looked like. There wasn't nearly the first head pressure. The hallux didn't even have any yellow on it. And so there's an increase in pressure here as well. If you also look, you can't see it as good here, but I'm going to kind of circle it. Here is my metatarsal, second and third metatarsal head. And it went from a 23% load up to a 28% load. So, and there's definitely a lot more pressure going through there. Also, I think we're going to see that there's a lot more pressure going through the heel rather than what I had at the time of his surgery there. So now we're going to move over to the curves and see if this is the case as well. So here I've selected the maximum pressures. You can change this around to how you want. But to be comparative to the 2018 here, we can kind of see how the rear foot, again on the left, is still quite a bit behind the forefoot here. It looks like the equinus still had, my procedure still is better than before because this is still more pressure than it is on the left side, but it's definitely not as great as it had been. We're also seeing that there's a lot of pressure underneath the second metatarsal head area. This particular button right here would tell me how much time they're spending in a particular spot. But more or less, you can just see the spike in the pressure that comes through the metatarsal heads there way too early. This is the forefoot. This would be the first metatarsal, and then the toes coming through here. So I can tell that the Cartiva implant is no longer letting him dorsiflex as well to the hallux. I can tell that the plantar plate the second metatarsal head has way more pressure than it did before, and this has led to a plantar plate injury there. In hindsight, I think about what I could have probably done different, and I think it would have been better to constantly make sure he was coming in for diabetic inserts. We had made him one in 2018. He kind of skipped a couple years and then came back with this. So I think if he had been a little more consistent, we could have offloaded this better. I took a 3D scan. You can kind of see a little bit of the callus underneath the hallux over there to go along with this picture. So I got just simply, I'm going to go through how I designed his diabetic insert to try to change what's going on currently today with his foot. So here's his image. I'm going to show you the left side just to give you how I would go about this, knowing that the second metatarsal head has the pressure point, and then I have an ulcer starting or a callus underneath the hallux. So here I pretty much built up my arch. You can choose your arch height. You can choose the thickness. You can choose your heel cup, and it will fill in right towards the actual pressure, or you can use your 2D or 3D images, however one you want to use. But this is pretty accurate. It created my arch. Now I'm bringing in a metatarsal bar. I'm going to increase this a little bit, just get pressure off the second and third metatarsal heads. And then I'm going to come in and add a skive as well to also help with the pronation, get them off the medial column, and try to distribute the pressures a little bit here. I don't have Paul Graham's nice subtalar joint axis with me today, but you can actually bring in your 2D image when you mark it, and it shows up right here like he was showing before, which would have been a little bit more precise than the pressure scan. Now I'm selecting the area that I want to depress or create a small little divot. That's in my second metatarsal head area right here. So once I have it selected, I feel comfortable with that area, I can decrease the thickness, and then I can smooth it out right here. And I'm going to just go ahead. That puts me a nice little divot into that area where I can see pressure-wise there's a lot of pressure going in there. Now I know that there's a hallux ulcer here as well, so I'm going to go ahead and just bring down a little bit underneath the first ray as well, kind of create a little drop so that I can put less pressure on that as well. So this is just me putting it in the right spot, and then I'm going to decrease the thickness and then smooth it out. Okay. And then once you got this, it's pretty much just a matter of coming in and pushing the pressure into the orthotic. So everything that he did when he walked, I'm just going to go ahead and push it right in right here. You can see it change. There went his foot built into the orthotic. And my met pad and everything arch remains there still. So I still have all that. Now I'm just smoothing off the edges to make it look a little more polished. And then I'm going to come in and thicken up the orthotic a little bit just because it's going to get a little thin right where I have it. Here you can kind of see just what I have built, different angles of it according to his pressure. And I think I'll hit this button. You'll see it get a little thicker, and that's the orthotic there. Anyway, that was pretty much how the one I wanted to share that I kind of went through with a patient recently. I'm going to go ahead and switch back over to me not sharing screen.
Good stuff.
Yeah. So anyway.
Really good stuff.
I couldn't see comments because I had my screens up the whole time. I don't know if there are any questions I need to answer. I can go over that. But
yeah, so I think what we're going to do too is we're going to likely answer all the questions during the roundtable. Okay. I think that's probably the best bet. So there are a few here, and we have some other ones as well. So we'll clip these out and then bring those over to the roundtable.
Great. Awesome.
All right. Awesome. All right. We'll see you over. Okay. All right. Take care. All right, guys.